Um, I want you to imagine a scenario that is, well, it's incredibly frustrating, but unfortunately, it's all too real for a lot of people.
Oh, absolutely. It's a very common nightmare.
Right. So imagine spending years, maybe even decades, living with this chronic, just debilitating head pain.
Hmm.
And you are trying treatment after treatment. I mean, you're doing the physical therapy, you're taking all the prescribed medications, you're changing your diet, you're getting multiple scans.
Right, you're taking every box.
Exactly. And yet, nothing is working. The pain is just always there, radiating up the back of your head, making normal life almost impossible.
Yeah, it takes over everything.
It really does. And then, after all that time, the money spent and the sheer suffering, you discover that you and your doctors have been looking for the source of the problem in completely the wrong place.
Yeah, it's a devastating realization to come to because, we tend to think of modern medicine as this perfectly precise map, right?
Sure.
Where every symptom leads clearly to a cure. But there are still significant blind spots.
Yeah, definitely.
And for a very specific group of chronic headache sufferers, realizing they've been navigating one of those blind spots is an incredibly common experience.
And that is exactly our mission today. We are doing a deep dive into a really eye-opening medical document that, well, it breaks down the true causes of migraine and occipital neuralgia. We're going to map out exactly how these severe headaches develop over time, and we are going to uncover a major diagnostic trap in modern neurology.
A trap that catches a lot of very smart doctors, I might add.
Right. And most importantly, we're going to learn how distinguishing between two very similar sounding nerve issues can literally save patients from unnecessary invasive spinal surgeries.
Which is huge.
Absolutely huge. Okay, let's unpack this. Because to understand why things go so wrong in the treatment phase, we first have to understand the baseline.
Where it all starts.
Yeah, like if we were looking at two different people, why is one person just naturally more vulnerable to these massive headaches in the first place?
Well, we have to start at the foundation, which brings us to a mix of genetics and anatomy.
Okay.
Because there is a very well-documented hereditary component to migraines. I mean, a lot of patients can point straight to a parent or a sibling who has the exact same pattern of headaches.
So it literally runs in the family.
Exactly. And researchers have actually identified specific genetic variants for this. Like, for example, there are mutations that affect calcium channel function in the brain.
Oh, wow.
Yeah, and those are linked to certain inherited migraine syndromes.
Yeah, some chest. So, we're talking about how the cells are chemically communicating with each other.
Right. It drastically changes the excitability of those neurons. You can basically think of it as the volume dial on the nerve being turned up too high.
Ah.
So the nerve fires off pain signals much, much more easily than it should. But for the vast majority of patients, there isn't just one single, headache gene that you can isolate on a simple blood test.
Right.
The tendency toward getting migraines is usually polygenic.
Meaning a whole collection of different genes working together.
Exactly. It's this complex combination of many small genetic factors that constantly interact with a person's environment.
Mm-hmm.
It's a recipe, not a single ingredient, that determines who develops a migraine and just how severe that inflammatory response is going to be.
That makes a lot of sense.
But genetics is really only half of that baseline story, though.
Okay, what's the other half?
The other half is purely architectural. It is the physical anatomical blueprint of the patient.
Like how they are literally built on the inside.
Precisely. There is this growing recognition in the medical field that some people are simply constructed in a way that predisposes their peripheral nerves to getting compressed.
Really? Just the way they're built.
Yeah, we're talking about microscopic variations in anatomy, like the thickness of the muscles in the back of the neck.
Yeah.
Or the density of the fascia.
Fascia is that tough connective tissue, right?
Exactly, the tissue wrapping around those muscles. And it's also about the exact winding path a nerve takes as it travels from the spine through that tissue and up to the scalp.
Oh, I see. So it's kind of like a house's plumbing blueprint?
That's a great way to look at it.
Like if you have the pipes, the nerves routed through incredibly tight wall spaces, which would be the muscles and fascia in this scenario,
Right.
it is going to take significantly less pressure to cause a blockage or a leak compared to a house that was built with, wide open walls.
Exactly. If the walls are already tight, even a tiny shift causes a massive problem. What's fascinating here is that this anatomical variability perfectly explains something that frustrates so many patients and doctors alike.
What's that?
It explains why two people can have the exact same stress levels, the exact same lifestyle, maybe even sit at the exact same type of desk looking at the same monitors all day long.
Right, doing all the same things.
Yeah, and yet they have completely different headache experiences.
Oh, wow.
One person gets a mild stiff neck, and the other is just down for 3 days in a dark room with an occipital neuralgia flare-up.
So it's not that they're doing anything wrong, they just have tighter walls, to
Right.
use that analogy.
Yes. The person with the severe headache simply has less physical tolerance for inflammation or muscle tension
Mm.
because their nerves are already navigating a much tighter anatomical tunnel.
Okay, so if I have these naturally tight biological walls in my neck, I'm primed for a problem.
Mm-hmm.
But people aren't usually born with these massive chronic headaches. Something actually sets off the cascade, right? Like, does someone just wake up one day and the nerve is suddenly trapped?
Usually, no. I
Mhm.
mean, it requires an event to push that tight anatomy over the edge.
Okay, like what kind of event?
Well, in this context, that event is very often physical trauma.
Mm-hmm.
We're talking about whiplash from car accidents, sports injuries, a bad fall, or, really any direct blow to the head or neck. Trauma is one of the most common starting points for chronic, unyielding head pain. The issue is that trauma affects the nervous system in a few different ways, which makes post-traumatic headaches notoriously difficult to sort out.
Right, because it's not a broken bone where you can just point to a fracture on an x-ray and say, there's the pain.
Exactly. First, you have the direct injuries. The trauma can injure a cervical nerve root right at the spine itself, like if you herniate a disc or disrupt a joint during the impact of a crash.
Ouch. Yeah, that makes sense.
Or it can injure a peripheral nerve directly by stretching it or bruising it as the neck violently snaps back and forth.
Right.
But there is a third mechanism, and this one acts as a hidden threat.
A hidden threat, like a delayed reaction.
Yes, the delayed muscle-mediated mechanism. When you suffer trauma to the neck, the body immediately tries to heal that damaged tissue.
Which is what it's supposed to do.
Right. But during that healing process, the surrounding muscle and fascia can scar. The tissue tightens up, and it can actually permanently thicken.
Oh.
And as that scar tissue forms, it gradually narrows the tunnel the peripheral nerve has to travel through. This doesn't happen overnight.
Right.
This structural thickening happens over months, sometimes even years, after the original injury felt like it had completely healed.
Wait, I need to push back on this a little bit.
Sure.
Because if someone is in a bad car crash, they usually get scanned right away. They go to the ER, they get an MRI or a CT scan of their neck.
They do, yes.
So if the muscle is scarring and essentially crushing a nerve, why wouldn't a doctor see this happening and just address it?
It's a great question. The problem is that standard cervical spine imaging, the MRIs and CT scans ordered in the ER or by a typical neurologist, they're designed to look at structural issues of the spine itself.
Oh, I get it.
They are calibrated to look at the bones, the discs, and the spinal cord. A slowly developing peripheral nerve entrapment hiding out in the soft tissue of the neck muscle.
It just doesn't show up.
Exactly. It simply doesn't show up on those scans in a definitive way.
So it's invisible to the specific test they are running.
Yes. The patient is sitting there in absolute agony, and the treating physician is looking at a completely clean scan of the cervical spine.
That is so frustrating.
It is. Both of them misunderstand the post-traumatic headache. The doctor might focus on the original impact, or they might look at some mild, normal wear and tear on the vertebrae and blame that.
Completely missing the soft tissue issue.
Right, completely missing the fact that the nerve is being suffocated by scar tissue an inch away in the muscle.
That is maddening. You're looking right at the area, but with the wrong lens.
Exactly.
And trauma doesn't just cause scarring, right?
Yeah.
According to the sources we're looking at, it can also fundamentally loosen the structures holding the head up, which creates a whole different set of problems.
Yes, this introduces a really crucial piece of the diagnostic puzzle, craniocervical instability.
Okay, what exactly is that?
So the craniocervical junction is the region where the skull meets the very top of the cervical spine. It relies on a very complex web of ligaments to stay stable.
Ligaments being the connective tissue holding bone to bone.
Precisely. And when those ligaments become lax or loose, it causes massive problems.
Where does that looseness come from?
This laxity can come from cumulative mechanical stress over a lifetime, or it can come from that traumatic whiplash we just discussed.
Right.
Or it can even come from underlying connective tissue disorders like Ehlers-Danlos syndrome or EDS.
Oh, yeah, I've heard of EDS.
Yeah. So when those ligaments are too loose, the vertebrae at the top of the neck shifts slightly more than normal during everyday movement. The head is basically bobbing around on a loose hinge.
Okay, I want to make sure I'm synthesizing this correctly.
Go ahead.
Because the neck is suddenly unstable and bobbing around, does the body try to build its own natural cast by permanently clenching the neck muscles to hold the head steady?
Yes, exactly.
Which in turn accidentally crushes those peripheral nerves passing through those already tight tunnels we talked about.
That is exactly what happens. It's called chronic muscle guarding. The central nervous system senses the instability, it panics, and it orders those neck muscles to lock down to protect the delicate spinal cord.
Which makes sense from a survival standpoint.
Right. But by creating that rigid muscular cast, the body massively increases the tension in the exact muscles that the occipital and other peripheral nerves have to pass through.
So the body's own defense mechanism becomes the very thing causing the excruciating pain.
It's a tragic irony, really.
Yeah.
And this creates a highly complex, mixed picture for a doctor.
Because there's so much going on.
Right. You have a patient with unstable vertebrae, which might be irritating the nerves at the spine, and you simultaneously have chronic muscle guarding, which is crushing the peripheral nerves out in the soft tissue.
Right.
It requires incredibly careful sequential evaluation to sort out how much of the pain is coming from the spine itself and how much is coming from the surrounding muscle.
I want to pause here because this complex web of pain, part spinal, part muscular, it leads directly to what our sources call the most critical distinction in all of headache care.
It really is the dividing line.
Right, the difference between the spine and the peripheral muscle.
Yes, we have to clearly define the difference between a cervical nerve root compression and a peripheral occipital nerve compression.
They sound really similar.
They do, and they feel similar to the patient, but anatomically and surgically, they are worlds apart.
Walk me through the geography of a nerve root compression versus a peripheral compression.
Okay, so a cervical nerve root compression happens right at the spine. It's usually located at the neural foramen, which is the little opening between two vertebrae where the nerve exits the spinal cord.
Okay, so right at the center.
Right. This is typically caused by a bulging disc, bone spurs, or spinal arthritis. The pain usually follows a broader pattern, often radiating down into the arm or the shoulder, along with the neck.
Oh, I see.
To fix this kind of mechanical compression, you need major spine surgery, a foraminotomy, a discectomy, or a spinal fusion.
You are literally operating on the bones of the neck.
Exactly. It's a major structural intervention. But peripheral nerve compression happens well outside the spine, downstream in the muscles, the fascia, and those soft tissue tunnels we talked about earlier.
Tight walls.
Right. The pain here is highly concentrated at the base of the skull, and it radiates up over the scalp, sometimes all the way to the forehead or behind the eyes.
Okay, so how do you fix that one?
To fix this, you absolutely do not touch the spine. You perform a peripheral nerve decompression, which is a surgery strictly in the soft tissue to release the tight muscle or scar tissue.
Here's where it gets really interesting, because you might be thinking, okay, one is at the spine, one is out in the muscle. Just ask the patient where it hurts and figure it out.
If only it were that easy.
Right. But the anatomical trap here is wild. The source explains that the greater occipital nerve, which is the peripheral nerve out in the muscle, is actually formed from the fibers of the C2 nerve root at the spine.
That's the kicker. They show the exact same origin point.
So, because they share that origin, the pain signals they send back to the brain feel identical to the patient.
Yes.
A pinched C2 root at the spine feels exactly like a pinched occipital nerve out in the muscle. The brain literally cannot tell the difference.
You can't. And if we connect this to the bigger picture, we can see exactly why so many patients are funneled into the wrong treatments.
It makes total sense now.
Right. Both conditions cause head and neck pain radiating over the skull. Both can happen after a car accident. Both can even exist in the same patient at the exact same time.
Wow.
If a doctor relies solely on the patient pointing to the back of their head and then looks at an MRI showing some minor age-related wear on the C2 vertebrae,
they're going to assume the spine is the problem. Because the nerves are so intimately connected, standard diagnostic assumptions are actually lying to doctors.
Unfortunately, yes.
Let's look at the misdiagnosis trap and something the documents call the flawed nerve block.
This is where things get really tragic. A substantial number of patients undergo major, highly invasive cervical spine surgeries, literally fusing vertebrae together in their neck, specifically to cure their headaches.
Which is terrifying.
It is. They go through the risks of the surgery, they go through the grueling physical recovery, only to wake up months later with the exact same headache, unchanged.
Because the imaging showed C2 issues, the doctor assumed the spine was the culprit and they operated on the spine.
Right.
But the real problem was further down the nerve, wrapped up in the muscle. Now, I know doctors do tests before operating, so how are they missing this?
Well, the standard test used to confirm spine surgery is a cervical nerve root block. Under an X-ray, a doctor injects numbing medicine directly onto the nerve root at the spine.
Okay.
If the patient's headache goes away temporarily, the doctor concludes that the spine is the definitive source of the problem, and they proceed with the operation.
But the document points out a massive mechanical flaw with this logic. Let me try this analogy for you.
Let's hear it.
It's like you are trying to figure out why a lamp in your living room is flickering. To test it, you go down to the basement and you turn off the main power breaker to the whole house.
Right.
The lamp goes out, so you assume the breaker box is broken and you spend thousands of dollars replacing the breaker box. But actually, the breaker box was fine. The power cord on the lamp in the living room was just frayed.
Exactly.
You interrupted the signal at the main source before it ever reached the true problem.
That is a perfect analogy.
Yeah.
The cervical nerve block at the spine is turning off that main breaker. It anesthetizes the nerve root before it branches out and travels into the muscle.
Oh, man.
So the patient's pain goes away because the signal is blocked entirely from the root. That positive result does absolutely nothing to tell you where along the pathway the compression truly sits.
It just tells you the signal stopped.
Right. It could be at the root, or it could be a frayed cord 3 inches away in the muscle. The block interrupts the shared signal regardless, generating a false positive for spine surgery.
This raises an important question. If the spinal nerve block produces false positives and essentially lies to the diagnostic process, how do doctors correctly test a patient?
Right.
Like, how do we find the frayed cord without turning off the whole house?
It relies on basic anatomical logic, yet it is skipped with alarming frequency. The correct diagnostic sequence is that a physician must always perform an occipital nerve block first.
Meaning a block out in the periphery, not at the spine?
Yes. You inject the numbing medicine at the peripheral site, out in the neck muscle, far away from the spine itself. You target the specific downstream area where the soft tissue tunnel might be crushing the nerve.
So the logic here is completely inverted from the spine block.
Exactly.
If the peripheral block relieves the headache, then you know definitively that the problem is peripheral. The entrapment is in the muscle because you only numbed the end of the line.
Yes. If the pain goes away, you found the exact spot in the soft tissue. But if you do the peripheral block in the muscle, and the patient still has their headache, then you know the true source of the pain must be further upstream.
It has to be at the spine.
Right. If numbing the downstream nerve doesn't stop the pain, the compression hasn't been addressed. That is when a doctor can confidently say, this is truly a spinal issue, let's evaluate for cervical spine surgery.
Wow.
Skipping this step and going straight to the spine block means the surgeon is essentially flying blind.
So what does this all mean? How does this change the reality for people suffering from these conditions?
That's a game changer.
Because this isn't just theory, right? This is actively changing how medicine is practiced by specialists who actually recognize this blind spot.
Exactly. It shifts the entire focus of treatment from incredibly invasive spine surgeries to highly targeted, less invasive peripheral surgeries.
The source material actually points to a very specific real-world example of this approach in action.
Oh, yeah.
It highlights Dr. Adam Lowenstein and the Migraine Surgery Specialty Center. They work specifically with migraine headache and occipital neuralgia patients, and their entire approach is built on this exact sequential diagnostic logic.
Which is how it should be done.
Right. They aren't just guessing based on a pain map or a blurry MRI.
They systematically rule out the spine by testing the peripheral nerves first. And by doing that, they're able to bypass unnecessary spine fusions for a huge number of patients.
That is incredible.
It really is. If the peripheral block is successful, they provide long-term relief through a much smaller outpatient nerve decompression surgery.
Oh, so it's not even an overnight hospital stay.
Usually not. They simply go into the soft tissue, release the tight muscle or scar tissue that's choking the nerve, and leave the spine completely untouched.
It's the difference between demolishing the foundation of your house to fix a plumbing leak versus just opening up a small patch of drywall where you know the pipe is actually pinched.
That's a great way to frame it.
The precision of the diagnosis completely dictates the scale of the solution.
And that precision is what has been missing for so long in chronic headache care. We have to stop assuming that because pain is felt in the head and neck, it must originate in the bones of the cervical spine.
Right.
The soft tissue, the muscles, the fascia. They are a dynamic, constantly changing environment, especially after trauma. They're just as capable of causing disabling neurological pain as a herniated disc.
I want to speak directly to you listening for a second because the ultimate takeaway from all this research, from understanding the genetics, the trauma starring, the unstable ligaments, and the shared nerve
I get
pathways.
the picture.
Right, the main takeaway is the absolute necessity of sequential diagnostic testing. You cannot rely on assumptions. You cannot rely purely on where the pain is located, and you cannot rely solely on a standard spinal MRI to tell the whole story.
No, you really can't.
If you or a loved one are ever sitting in a doctor's office and you are told that a major cervical spine surgery is the only option to cure your chronic headaches, well, you now possess a vital piece of knowledge. You know to stop and ask about a peripheral occipital nerve block first. You know how to test the lamp cord before you let someone replace the breaker box.
That's right. Knowledge really is the best defense against misdiagnosis. Understanding the mechanics of your own anatomy gives you the vocabulary to advocate for yourself.
It really does.
And they'll leave you with this thought. If our own natural healing processes, like forming scar tissue to heal a whiplash injury or permanently clenching neck muscles to stabilize loose ligaments, can inadvertently create a lifetime of chronic nerve pain simply by shifting a few millimeters of tissue,
Right.
it forces a much larger question. How many other mysterious chronic conditions in the human body, things we currently treat as incurable diseases, might simply be anatomical miscommunications?
Oh, wow.
Just tiny mechanical entrapments waiting to be correctly mapped and decompressed, rather than permanent conditions we just have to live with.